Okay, guys, have your discussion aid for you this afternoon. The title is Why Americans Pay More for Health Care Than Any Other Nation. The U.S. healthcare system is often described as paradoxical. It delivers some of the most advanced treatments in the world, yet produces poor population health outcomes compared to peer nations. Americans spend far more, over 4.9 trillion annually as of 2023. But life expectancy lags behind countries that spend half as much. The reasons are not simply cultural or behavioral, they are embedded in the structure, uh, incentives, and economics of the system itself. The 7 core drivers of higher costs. Procedure first, incentives. Payment models reward physicians and hospitals for volume, tests, procedures, and admissions rather than prevention or coordination. For example, a cardiologist is reimbursed more for pricing a stent than for counseling a patient or on lifestyle changes, even if the latter prevents disease progression. This screws care this skews care toward interventions rather than long-term health. Opaque pricing and weak consumer leverage. Unlike most markets, patients rarely know the true cost of care until after services are delivered. Prices vary dramatically. An MRI might cost $400 in one facility and $4,000 in another because insurers negotiate behind closed doors. Consumers cannot exert meaningful price pressure. Extraordinary administrative overhead. The U.S. spends more on billing, coding, prior authorizations, and insurance paperwork than on treating major diseases like cancer. Each insurer has its own rules, forms, and networks, forcing providers to maintain uh, amenities of staff or armies of staff just to navigate reimbursement. This complexity adds billions without improving outcomes. High unit prices for services and drugs. Americans don't necessarily use more care than peers. They pay more per unit. A hip replacement and insulin vial. Or a CT scan costs multiples of what it does in Europe or Canada. Outpatient care. Visits, imaging, minor procedures accounts for much of the excess spending. Market consolidation and pricing power. Large hospital systems and physician groups dominate local markets, giving them leverage for demand higher rates from insurers. Even routine services like lab tests or outpatient visits are billed at facility fees. Once they are absorbed into hospital owned networks. Costly intervention and rapid adoption. The US is often first to adopt new drugs, devices, and therapies. While this accelerates access to cutting edge care, it also means paying premium launch prices before competition or negotiation lowers costs. Gene therapies, biologics, and robotic surgeries exemplify this dynamic. Demographics and chronic disease burden. An aging population and rising prevalence of diabetes, obesity, and cardiovascular disease, increased demand for intensive ongoing care. Chronic conditions drive hospitalizations, medications use, and specialist visits, magnifying costs in a system already characterized by high prices. Why these factors persist? Fragmented governance, multiple payers, benefit designs, and state federal rules create inefficiency and prevent unified cost control. Misaligned incentives, fee for service, rewards, activity, not outcomes, Hospitals profit from admissions, not from keeping patients healthy. Information asymmetry. Patients and employers lack clear signals about prices and quality, undermining competition. Political economy of innovation. Strong cultural and political support for biomedical progress prioritizes rapid access even at higher costs with limited tools to negotiate prices down. Consequences for equity, outcomes, and debt. Poor outcomes despite higher spending. Preventative care and social determinants are underfunded, contributing to shorter life expectancy and higher infant mortality compared to peers. Household financial strain, premiums, and out of pocket costs rise faster than wages, leaving families vulnerable to medical debt. Fiscal pressure. Healthcare consumers nearly 1/5 of GDP, straining public budgets and threatening sustainability of Medicare, Medicaid. Practical levers of change shift toward prevention and primary care, expand value-based payment models that reward outcomes and community, enforce price transparency, require standardized disclosure of costs, and incentivize use of lower cost, high value providers. Simplify administration, harmonize billing rules, reduce prior authorization burdens, and adopt common data standards. Counter consolidation, scrutinize mergers, enforce antitrust laws, and promote site neutral payments to reduce pricing power. Align innovation with value. Use outcome-based contacts and comparative effectiveness research to ensure new therapies deliver real-world benefits. Address chronic disease and aging. Invest in community-based prevention, caregiver support, and integrated models of care to reduce higher cost utilization. The bigger picture, the U.S. healthcare system is not simply expensive because Americans are sicker or demand more care. It's it is expensive because of structural ineffectiveness, pricing, demographics, and policy choices that prioritize intervention over provider uh, revenue over prevention, and equity reform requires not just technical fixes but a rebalancing of values. Shifting from a system that rewards intervention to one that sustains health. Would you like me to map these 7 drivers into framework for community level action, something that could guide local healthcare coalitions or caregiver networks to or in translating these systematic issues to practical strategies. Okay, guys, that's A for you. I'll be back on shortly with B. Give me a bit for that, please, and I'll have it back on for you. For now, Gator Wellness, take care, folks.